Okay, so it was good. I wasn't sure if Lex would cover job exposure matrices, so I did include some interaction on that as well. So don't worry, I'll explain a bit more on that. So I will talk about the development of this particular JEM for COVID-19, and with a special focus on how we did that with well, people from different countries, and to assign that for different countries. So that's also what I would like to tell you about this experience. So I think the same for Lex's his lecture. Please let me know if you have any questions. Put them in the chat, and I'll try to answer that and see if we can incorporate that. And so see if I can move. Yeah. So just a brief introduction who I am. Because I see a lot of names I haven't seen before. So my name is Susan Peters. I'm an occupational epidemiologist and exposure scientist. And yeah, as you can see, my research focus, of course, is on exposure assessment and methods in that. And then to apply them to chronic disease epidemiology. And then you need to think of, well, cancer, neurodegenerative and respiratory diseases. And I'm leading the Occupational Health research group at the Institute for Risk Assessment Sciences at Utrecht University. But yeah, I will talk about today is the COVID JEM, which is a slightly different topic for me in terms of the exposure side, which makes it very interesting, I guess. But in the terms of methodology, it's a typical JEM. So what I will talk about today is to give you some background on what we aim to do, and then the whole process of developing this JEM, which is the major part, and I will focus a bit more on the regional differences, and then the validation of this JEM. So what were we aiming to do? So the question was, of course, when the pandemic hit, we were all affected by this, but we were wondering, well, we saw occupational workplaces also to play a role in this, but yeah, the question was, to what extent does the workplace, well, what role is there of the workplace in the COVID pandemic? And we thought it would be nicer if we would have a tool to assess the risk of an infection by COVID in the workplace, and then at the general population level, so that you can do that for large populations. Then, of course, you're gonna ask yourself, well, what are the options there? Of course, if you have a large population, you can ask for self-reports. This is just a general way of doing exposure assessment. So you can ask people if they are exposed by asking that particular question. The other thing is, of course, you can send out questionnaires with a lot of specific questions, and then let an expert look at every single case and assess whether somebody might be at risk of getting infected by COVID. And then the third option basically is a job exposure matrix. And you already know from the title that that's the option we choose. And I will explain you a bit more why we choose this and what the particular features are of a JEM. So what is a JEM? It's, well, very basically, it's just a matrix where you have an axis with the occupation, so the job title, and there is a list of exposures, an exposure axis there. So if you look at this, which is a very basic graph of how a JEM might look like. So you have job, A, B, C, D, and so forth. And then for exposure X, and that might be asbestos, it might be silica, it might be magnetic fields, whatever you are interested in, and you sign whether somebody's exposed, yes or no, or the level that somebody's exposed. So say job A is non-exposed, job B is low exposed, and so forth. So it's basically just a list of jobs and the level of exposure linked to that job. And with this tool, you can basically translate job histories from a cohort study, for example, or a case control study, where you have, if people have listed their jobs for what they've done over their life. For every single job, you can assign an exposure level using this matrix. And it's in a systematic way because there's no expert opinion for that particular job at that moment, or all this information that is additional to the job title. And it's unbiased in the sense that it doesn't make any difference whether somebody is a case or not. So of course, every method has their advantages and disadvantages. And just to have these three methods that I indicated before, what their advantages are and disadvantages are, and then of course why we would choose a JEM in the end, is, well, if you do self-assessment, it's relatively low cost. You can just ask somebody, were you exposed, yes or no? But of course, the main problem is there. Does the worker actually know what you want to assess? Do they know what the exposure is? And so it's a lack of knowledge, but also difficult to recall. If you ask somebody what were you exposed to 20 years ago, people will not recall well. So you're really dependent on what the people report. So that's a problem with self-assessment. Then expert assessment. The good thing is that you can take into account all available information. So you have job title, but also information on tasks, industry, well, the time periods, all that information an expert can take into account. But you can imagine that if an expert has to look at all this information for every single job, it's very, very labor intensive. So that costs a lot of money in terms of paying these experts, and it costs a lot of time. And then the other thing, of course, is subjective. And what I mean there, of course, well, the expert is a black box. How does he make the decision? But also, if somebody's tired, you might make different decisions. There's a learning process. So if somebody's just started assessing these exposures, they might make different choices than what they do if they are more experienced. So there are all these different aspects, and different experts might have different opinions. So it's subjective in that sense. So then if we move to a JEM, well, the advantages are it's low cost, because once you've developed it, you can easily link it, just link the job title in the JEM with the job title in the core data, and you get an exposure level. And the good thing is that it's standardized within that study, so not dependent on how what timing of the expert, if he was tired or not. It's always the same assessment, and it's very transparent that you know, well, you can see what's in the JEM and what the assessment was, and it's also standardized between studies. So if you have a cohort in the Netherlands and you do that, and you have a cohort in another country, you do the same. You apply the same JEM, you have the same same methods applied, and there's no difference in when this was done or where this was done. So you have the same method and the same assessment level as well that you get as an output. Of course, the JEM has some disadvantages as well, as all have. And the major disadvantage is that a JEM assumes that within a group, or within this here, it's a job title, that you assume that the exposure is homogeneous, so that everyone with that particular job title has the same exposure level, because that's what you assign. And as you will have heard from Lexi's talk, that's not how the reality is. So yeah, we would really be aware of this this drawback. Keep that always in mind if you use a JEM. And of course, with every method, there's a trade-off of what you use, and the major thing is that you know what are the assumptions that you make. So assume that it's all the same. But so it really also depends on the type of exposure that you assess, how much it will affect your outcome. So I've put a few examples here where the exposure is really dependent on the task rather than on more than on a job title itself. Then JEM might not be the best solution. So welding, a lot of people do weld, but they might not have the job title of welder. So it's a task that many different jobs might, in many different job titles, people might do some welding and get exposed to welding fumes, for example. But on the job title itself, you would not think that, well, not all people would do the welding. And the same with degreasing, it's very task specific. So with task specific jobs, task specific exposures, GEMs might not be the best option. Just on a side note, there are many GEMs around. And within the OmegaNet program, we have made an inventory of all exposure assessment tools. Well, it's not complete, and if you have tools that are not in there, please feel free to add it to the inventory. The inventory is just a dynamic thing. It will, well, it's open for new entries. But if you're looking for a GEM that there is, please go to it's occupationalexposuretools.net, and then on the inventory you can see a list of GEMs. And you can select GEMs by country, for example, or by exposure that you're interested in. And I think we have about 37, 38 GEMs included in there at this stage. So, and some GEMs assess just one exposure, other assess, well, even hundreds of exposures. So a lot of tools available there for specific exposures if you're looking for them. So then go to the COVID-19 GEM that we developed. So we decided to, for the tool to assess the risk within the general population, we decided to use a GEM. And as you've seen in my, well, the basic graph is that you need a job title, job axis there. And there you can choose an occupational coding system. There are international coding systems, there are national coding systems. We chose the international one, ISCO, because we wanted to cover multiple countries. And we choose the 2008 system because it's most recent and you have the more modern jobs. So especially, well, of course, we were interested in the very recent times. This makes more sense than having the 1968 version, for example, which might be more useful for exposures in the past. But here we obviously were interested in the modern jobs. So that's what we choose in 2008. And then we had to develop the dimensions and think of what are the factors that determine whether you are at risk of getting an infection. And here a lot of discussion was a lot of discussion between the experts, and I'll come back to that later. But we defined 8 dimensions where the GEM was built up from, and these included determinants of transmission risk, then mitigation measures, and social factors. And because we thought there were various determinants of the actual risk, rather than just saying, well, for this job, the risk is 0 or high, but I'll come back to that with a bit more explanation. So how did we do this? How did we start it? We had 3 experts in occupational epi and exposure assessment for every country. And we had 3 countries. There was Denmark, the Netherlands, and United Kingdom. So 9 experts in total. And between each other, we discussed the definitions of the dimensions of the GEMs and how to interpret them, because that's as you can imagine, well, and I'll show you what we did and explain why this is so important as well, because I indicated before, if you do expert assessment, well, we're human beings, so we all have our own point of view, and that might slightly differ between people, and also between experts in the same field. They will still it's good to get the interpretation right. So to start with the transmission risk, so we had 4 different parts there, and the interpretation there is what we've tried to explain in the the text here, what we actually meant with that. So first, we defined 4 levels of risk. So whether there was no risk, low risk, elevated risk, or high risk. So these were the 4 scores that we assigned. And then the dimensions that we chosen were, first we thought it was important how many people you get in contact with. So in the first column, you will see this will basically be people working from home. So I guess a lot of us would have fallen into the first column. Because, well, if we do a lot of desk work, we can basically do that from anywhere. So we were, at least if I talk for myself, I've been working from home mainly for the last year and a half. So there will be no risk because you don't get any contacts with other people. And of course, this is outside your household because that's no occupational exposure. And then we had to decide, well, what is low, elevated, or high risk? And of course, this is very arbitrary, and we can discuss, and we have discussed about it a lot, of course. So we said less than 10 people, 10 to 30, and over 30. So it really, yeah, of course, you can work at an office and just encounter 1 or 2 people a day. That's completely different than that you see clients coming in a shop all day through. So that is the number of contacts, but of course, also the type of people is important. Again, the home workers, they're always in the no risk column. But then we thought it is important to make a distinction between whether it's co-workers only, then the general public, and then, of course, people who might have COVID. So patients that are suspected or are diagnosed. The reason we made a difference between co-workers and the general public is that the general public can basically anyone. And the idea would be, of course, co-workers can also come in sick, but we thought the risk was lower because it's more controlled, and we have regulations on, well, if you have cold symptoms, you stay at home or you test before you get into the workplace, things like that. So that's where we make that major distinction. The third dimension was indirect contact, so contact via surface or materials. And again, we made the distinction between co-workers and the general public. And then for the general public, we made the distinction on how many times a day. So if you might have some sharing materials with the general public with very few times a day, then it was lower risk of than that you had that all day through the whole day. The last one for the transmission risk was location. So mainly if you work indoors or outdoors, because of course outdoors there's a lot more, well, there's ventilation and a much lower risk of getting infected. And again, if there are any questions, please let me know. I'll hope that it's clear. So then there were the mitigation measures. So of course, we all have these measures in place to avoid contact and avoid getting infected. And here we had to, be pragmatic as well. So we said social distancing is 1 meter because I think in France, for example, it's 1 meter. In other countries as well. In the Netherlands, was 1.5 meter. In the UK, it was 2 meter. But we called it social distancing. So at least that you keep your distance from other people. And here, depending on whether it can always be maintained, if you can do it most of the time, but not always, that was practical. And the high risk group where it cannot be maintained, because, well, you can imagine that there are jobs that you really have to, well, there is a contact between a healthcare professional, for example, and a patient, or things like that. The second one was face covering. Here, if you had, if you could wear the face mask all the time at the work site, when you were around other people, of course. If you could do it, well, for specific activities, but not always when you were in proximity of others. There can be cases, I know, like, for example, at our workplace, the labs were still, well, they continued working. And at the lab, it was decided not to wear a face mask because there were other risks with having these masks rather than COVID alone, because they can get contaminated and you might get some other exposures than infection. So there are workplaces where you cannot always wear them. And the high risk when it's not possible at all to have these face covering, for example, sports, or if you're singing, or so there are of course jobs where people were not wearing face masks. And here we had a lot of discussions, and I'll get back to that, because especially, for example, in the Netherlands, in the beginning, there was a shortage of face masks. So is it the availability of the face mask or whether people actually wearing them? That was really, there was hard to find the specific interpretation there, and we decided to get to the point where face masks were available and people could wear them, but whether they would wear them or not, what we thought was most likely for the job title. That's what we focused it on. Precarious work. This was we did this in a slightly different way. So this was largely based on data. So whether for a specific job, whether there was income insecurity due to the pandemic. So if people would lose their job or not. And that's the idea behind this was, if you're worried about losing your job, you might still go to work even if you are ill, and resulting in a higher risk of people getting infected. And the same for migrant workers, because they're in a vulnerable position. They might, our idea was, if there are more migrant workers, the risks are higher because they are, well, same for the income insecurity. They might make different decisions there and have other housing conditions. So we made a distinction on the number of the proportion of migrants being in a particular job title, and that translating to a risk score. But I'll focus on the previous 6 more in the rest of the presentation. So how to get to fill the JEM? Here the experts again. So for the 6 first dimensions that I've explained, we used expert assessments, and one comment to put here, and I think that's important because the pandemic, of course, everything changed all the time. Every week there might have been different regulations and with lockdowns, and these things also differed by countries depending on the the infection rate. So what we stated as like the basic state where we developed the JEM for is a situation where the general measures are in place, so that you have to keep social distance, wash your hands, wear a mouth mask, but not in a lockdown. So that's where the JEM was developed for. And then we've put a supplement to it. If you are in a lockdown, you can override some of the assessments, but that's more of a later, extra instrument that you can use. But here, the JEM itself was developed for not being in lockdown. So people do work, but not, but still while keeping the other measures in place. So still in times of the pandemic. Here I've tried to explain the expert assessment process. And I was actually hoping I had it in several slides, I hope, but here it's all together at once, which is fine. Just focus on the first layer first. So where it says 1. So we had 3 different experts per country. And it doesn't really matter which country it is, but say this is Denmark. So we have 3 experts from Denmark, 3 experts from the Netherlands, and 3 experts from the UK. So they would all individually go through all the 436 jobs there are in ISCO 2008. They would just go job by job, given a level to every, each of the 6 dimensions. So score them from 0 to 3 and do that one by one. That was the first step. So the second step was combining all these scores and also comparing them. So we compared all these scores, and then not to come to a final score yet, but just to see how much we agreed and how much we differed. And then we had another meeting because we saw, well, where the major differences were, well, compare how we interpreted the assessment, and then we realized that some interpretations were slightly different, and so we discussed them, and we came to a consensus on how to interpret the findings. And you can say maybe, well, you should have done that before, and that's also what we tried. But then when you actually apply the criteria that you had described, that you actually apply them in on the job titles, you face different things you did not expect before, I guess. So and then that people then appear to interpret them slightly different. So that's why this step is really important, I think, to discuss how you assign them and come to a consensus there. So what we did again is then to review your own scores. So everyone went back to their own scores, and with this new, well, with this consensus meeting in mind, make changes where necessary. So that's what we did here in this line. So everybody did that again individually. Then the third step was to combine all these 3 assessments within a country. So all the Danish assessments were combined, the Dutch assessments and the British ones. And then we all got together per country and went through all the disagreements, basically. So you can imagine with 3 different experts, you will have slightly different opinions. And we had well, I can only speak for the Dutch one here, of course. Did a few meetings of a couple of hours to work through all the different, well, the disagreements. And the good thing, I guess, with having 3 is that you always, well, get a majority easily. So, or if someone has a very strong voice, then a strong opinion on a certain occupation. And we went through examples and stuff. So we came to one score for every cell per country. So for every job title, we had every of the 6 dimensions rated. But then again, you have a matrix for Denmark, a matrix for the Netherlands, and a matrix for the UK. So the 4th step was to combine these 3. So of course it is, these are 3 different countries, and we do acknowledge that there are differences between the countries, but we wanted to make sure that to compare the differences that there were, if there were actual differences based on a rationale that things were actually different, or that it was more on the interpretation. So we came together, so we had one person from each country in this last meeting, and we compared all the disagreements, basically, or the differences between the countries, and to explain to each other why we had chosen that. And we highlighted quite a few to review again. So sometimes we in the Netherlands shifted towards what the others had, because we had slightly different interpretation, and agreed that it was better to have it the other way. It always also happened the other way around, and sometimes we had another look and thought, well, this is actually how it is in our country, so we leave it as is. So some results and some to give you some idea of how well the experts agreed. So so these were, again, are the steps, the 1, 2, 3, the first 3 steps, and these are the 6 dimensions of the JEM. And I would like to highlight here the face covering, because you see that if we look at the first column, this is by far the lowest agreement. So it's well, the highest are the type of people and location. Well, location is indoor, outdoors, which is not so difficult to assess. But the face covering, like indicated earlier already, there was a bit of disagreement there. And we had a second step, so the reviewing, so why we made these assumptions. And then we realized that we had made some different interpretation there. So after reviewing our own scores again, this became slightly higher. Interesting is that the social distancing went a bit down. All the others were very, very similar. So this is, again, still having individual scoring. But of course, then you have a very individual point of view, and it's good to have different views from different experts together. And that's also what you see here. So we got closer together after the consensus meeting, so that we had only the consensus between the countries. Which I think was fairly good. It's not. I didn't expect that to be 100%. So that's yeah. That would be. I would be very. How do you say it? I wouldn't trust it really if it would be very, very high. I think that's what you just get when you get different people assessing these type of scores. And also, if you look at the explained variance, so where are the main differences? So this is still in the first step. So to get back to the first step, so when we all did our own rating, you see that most difference is overall is between the raters. So we a lot of differences between the different raters, but the interesting thing here was that for country, so there was not a lot of variance explained by country except for the face covering. And again, that is we realized that in the UK they had a different interpretation of what we had indicated for face covering. And I'll show you what happened with the face covering. So first was the 40 lot was explained by country. That's lowered when we discussed it within the group, but still there was some difference there, but it completely, well, almost disappeared, and it was largely explained by the jobs, which you would expect as well. So overall, you see this is the end for all of them. So all the, of course, rater is disappeared here because there's no individual rater anymore. There are only the 3 different countries, but most of the explained variance is within the job, which you would expect as well. And the end agreement, I think it's fairly good, the lowest for the number of people, which is very, as you might remember, it was below 10 to 30 and over 30 people, which is, yeah, it's hard to tell sometimes whether it should be 10 to 30 or over 30 people on a typical workday. But then to get to the country differences, and I think this is where we had some interesting discussions there, and there was it's nice because it's already hard for yourself to make these decisions on the specific job where you should rate them. Sometimes, yeah, you get, whether it should 2 or 3. So is it medium risk or high risk? But then again, I think we had a lot of jobs that were very similar. Well, so for example, finance managers, yeah, it's a job that can be done just at a computer at a desk. So we all agreed that they would be working from home most of the time, or don't encounter any other people with that. So that was all, we agreed on that between the different countries, which is also reassuring, I think, if we had the same assessment. And then and I've just highlighted a few jobs to give you an impression of the JEM. So for nursing professionals, we also very much in agreement. So we thought they were all at very high risk. They encounter a lot of people. They might encounter patients with COVID. They also share services and materials with other people. They work inside. It's impossible to keep the social distance. But the face covering we had at low risk because well, once the mouth mask and all the material was available, they are well protected. Another job are hairdressers, and this is again when all the hairdressers were working again, so not in a lockdown. We also had very similar numbers here for the different countries. But there are quite a few jobs that have different assessments, and I'm not highlighting them all here, but I'll come back to that in the exercise for you guys. So, but one that I thought was interesting and what we had a nice discussion on is the debt collectors. So the Dutch one you see here. So I had assessed that, and well, within the Netherlands, the 3 of us had assessed that as well. They will encounter some people a day. They will go to people's houses and confront them with their debts and well, get in contact with some people from the general public, so we had this assessment, which is very similar to the UK. The only thing is that in the UK they thought it was they would see more people, which, yeah, that's still debatable where the cutoff is. But then in Denmark, I thought it was quite curious that they were all considered as home workers. So I guess it's a different system and a different way of how these people would work. And we had some discussion on that, and this is what we decided to end up with. So this is just one example, and I'll get back to that in the exercise for you to look at others. So to get to the major limitations of this method, again, yeah, the heterogeneity between workers that we completely ignore, of course, here, that's a major issue. Especially a lot of these factors really depend on behavior as well. If you wear your mouth mask or not, if you keep your distance to other people, and we try to assess that for a complete job title, which is, yeah, on the one hand, of course, impossible because people have all their own behaviors. But on the other hand, I think the ranking between the different jobs is still valid, and it's also the best we can do, I guess, at this stage. And of course, if you are a healthcare worker, you have different risks and different at these different dimensions than when you can work from home. The other things we have been discussing and that are hard to incorporate are the rapid changes with this pandemic. Of course, the levels of regulation change all the time within a country, between countries. And then there's the different variants of the virus that also might have different characteristics, and we don't know what new variants will come up. And then, of course, vaccination. So we made it for 2020 when people were not vaccinated yet. But of course, if you have a high rate of high vaccination rates at some point, then this is also completely different than it was in 2020. Just a brief indication on the validation, because of course, well, it's nice to make such a JEM, but you really need to apply it. And when you want to apply it, you want to have some feeling of how well you assess the different aspects. So we had a master students comparing, applying this JEM to a Dutch survey, where they collected self-reported the aspects on how many people do you encounter during a day, and all these information on all these 6 dimensions. And the survey was data were collected in June 2020 and March 2021. We've also asked these people whether they were infected with SARS-CoV-2, which is a bit hard to tell, of course, because especially in the beginning, there was no testing yet. So people, they might say, I might have been infected. There was asked whether that was confirmed by a test or not, and also where the infection happened, which is, of course, also not always that obvious where you get infected. But this was the information we had, and we compared our JEM ratings, what we would have said for these people and what they said themselves. And in this survey, more than 8,000 workers were included, slightly more females. And we looked at how well the JEM ratings and the self-reported risk were correlated. And they were fairly highly correlated for most of the dimensions, except for the work location, which was slightly lower. So whether they worked inside or outside, and the face covering. So face covering was fairly low. Again, I think this is especially the face covering is very dependent on human behavior. So I think that's not so surprising that we didn't assess that as good. But I'm quite pleased about the first that the other dimensions are fairly. There was a good agreement there. And then when we looked at people who had, well, probably, of course, because we don't know for sure that they were infected with SARS-CoV-2 between March 2020 and March 2021. So almost 20% indicated that they thought they were infected. And of those people, about a third believes that they were infected at work. So that's the only information we had. But then when we looked at the JEM scores and the risk of getting infected, the people who were infected, we saw that there was quite a good, there was a good prediction of who was infected. So the JEM worked pretty good there if we compare that to the who we assessed as being home workers and having no risk according to our JEM. So this was a validation in the Netherlands. The next steps basically are we want to make this JEM available via the OmegaNet website, and then this can be applied to different cohorts. And of course, we ourselves also want to validate this in the UK and Denmark, but it can be applied to other countries as well. Also to compare to similar JEMs if they are being developed. We hope to make it available soon. We have a manuscript on the development process of this JEM submitted, and it's under review. So once that is published, it's easier to, well, if we make the JEM available, then it's clear what exactly is in the JEM, and it's described in way more detail. So what can you do with this JEM? What we hope that it's being used for is that it will give an idea of how much the contribution of occupational exposure risk is to the total burden of the pandemic, and also to have a basis of how you can mitigate this risk if we have future outbreaks, that we have a better idea where to focus on, what occupations are most important, where do the risks occur, so we can see, well, what we assess as being at infectious at risk compared to the actual reported infections, but also to see, especially in the long term as well, who is at risk of getting an infection and what are the side effects? Because even just being at risk and not even getting the infection might affect, mental health, for example, but also where at certain workplaces you might have more problems with the long COVID, for example. And I think the JEM can be applied in different ways. And I just wanted to point you towards a very nice editorial that was published recently by Sarah de Matthijs in OEM. And I think there's also, the title was, "Are Not All Workers Essential?" I think it's about, who are the essential workers? But I guess we really need to assess the risk in all occupations, and with a specific focus on the vulnerable groups. And have this in a systematic way of assessing where the work-related risks factors are, where the risks are. So I think this is a very nice read if you have time to look it up. And I just wanted to thank, of course, the other people involved. I did not do this by myself. So Karen Oudehengel took the lead in this effort, and of course, Lex, you have just heard as well, and then Ayuka Pronk and Sophie van der Veld is the master student who did the validation, and then people from Denmark, Sarah Stockholm, Henrik Kolstad, and Vivi Schlunsen, the three experts there, and people from the UK, Karin van Veldhoven, Jannes Basinas, and Mati van Tongeren, who did the assessments for the British part. And I just want to thank you on listening today, and please let me know if you have any questions now, or if you want to have access to the JEM or anything, please let me know.